the way we practice our discipline had changed. Everything had changed. And we thought that we should have something to look back, like a review of last 1 year of COVID time. And we have very fortunate to have with us a very, very distinguished personality from Mumbai to talk on COVID times, 1 year's lessons for obstetricians and gynecologists. Warren Buffett said, always look for three things in a person: intelligence, integrity, and energy. Our speaker today, Dr. Reena Jain Wani, who is having all these three qualities in abundance. She is a professor and unit head. Can I have a slide, please?
Yes.
She is a professor and unit head at HPT Medical College and Dr. R.N. Cooper Hospital. Reena is an intelligent, hardworking, sincere, and a modest individual. And I have been very fortunate to know her right from our residency days when we were co-registrars in KM Hospital. She is an excellent academician and a very intelligent and hardworking person. Besides being good in academics, she is a very down-to-earth individual. Her academic achievements are many. She has received 2 gold medals, 5 distinctions, and 24 prizes and different awards. She has been awarded Mog's S.N. Pandit Award 2017, Mog's Ganatra Trust Prize for contribution to social issues, Dr. R.D. Pandit Prize twice, and Dr. Duru Shah Best Committee Member Prize twice from Mumbai Obstetrics and Gynecological Society. She is a president of Mumbai Breastfeeding Promotion Committee 2019-20. She is a core committee member of FOXI Violence Against Women's Health from 2015 to 2021. She is a chairperson of FOXI Perinatology Committee 2015 to 2017. She is ICOG Governing Council member elect for 2021-22. Her academic achievements are many. She has been editor and co-editor of 14 books. She has been author of 2 textbooks. She has contributed 50 plus chapters in FOXI and other books. And to her credit, she has 75 publications in journals. She is an excellent teacher, PG and undergraduate teacher, and she was a teacher even during her residency days. I remember her taking beautiful clinics as well as her maternal mortality meetings, presentations at KM Hospital, where everybody used to listen to her with rapt attention. And it was a great teaching experience, Reena. She is a teacher for DNB, DGO, and MBBS. She is a FRCOG and she is a referee for MRCOG. She is a WHO certified trainer for adolescent reproductive and sexual health, DIPSI, CCICP, HDP, and a FOXI trainer. She has been nominated as Mumbai's top doctors by Internovation India Today in 2010 and 11. During residency days, Reena was best teacher. So we used to give her any topic and she would explain the topic in such a simple and lucid manner. And she would give a beautiful presentation. We are very fortunate to have Reena with us. And I would like to present Dr. Reena Jain Wani to all the distinguished people who have attended here. With a quote, I would say, wish all the best to Reena. जिंदगी में सदा मुस्कुराते रहो, फासले कम करो, एक सितारा बनो और हमेशा जगमगाते रहो. Reena, I am sure with your dedication, hard work, and intelligence, you are going to be shining star in the field of obstetrics and gynecology for years to come. And I am very proud to present Dr. Reena K. Bani for today's webinar, which is going to be on COVID times, 1 year's lessons for obstetrics and gynecology. Over to you, Reena.
Thank you very much, Dr. Satish, for this very kind introduction. And it's my pleasure and privilege to be here with all of you wonderful people to talk about the different concerns, challenges, and outcomes what we have seen for COVID in pregnancy 1 year down the line after the lockdown. And I'll also be touching upon issues about vaccination in women towards the end of my talk. Friends, Mumbai has become the hotspot. And as we know, there's a huge divide in healthcare services everywhere. India has everything if you have the resources to do it. And last year, गणपती आले आणि गेले, माता आली आणि गेली आणि असं वाटलं करोना गेला. पण असं झालं नाही. And in fact, they say COVID-19 should be renamed as COVID-21 because it has caused huge estimated loss of services. When we talk about women's health, let's just start from family planning itself. This is shown that in May 2020 itself, it had already caused a huge impact on because of unintended pregnancies, childbirths, abortions, which were often unsafe, and maternal deaths. And this COVID-19 virus, which is seen in the picture, and its spike protein with all the various ingredients, has been the source of much discussion and has impacted our life. Sustainable developmental goals, what we talk about, and in which we are talking about the impact on women's health, there has been such a negative impact right from SDG 1. No poverty, zero hunger, good health and well-being, everything is affected negatively by COVID. And now we are talking about that the COVID surge has sent us to breaking point, and Mumbai, Pune, Nashik may have crossed their peaks. And Mumbai, in fact, has been overtaken by other cities across Maharashtra. And in fact, the misuse or improper use of masks by the public because of pandemic fatigue has also been a laughing stock or a source of sometimes humor, which may not be so funny, because that is what is leading to problems. So in the next couple of minutes, I'll just briefly go through what were the changes we incorporated in our obstetric practice as gynecologists and obstetricians. We've changed down the 1 year. By screening patients at contact, we have followed the three important things of social distancing, hand hygiene, mask and eye protection, changing to video consultation, teleconsultation, phone consultation, reducing the number of visits wherever possible, even in India. And in fact, we had a wonderful oration from UK by Dr. Patrick O'Brien, who said that even in an affluent place like the United Kingdom, they have switched to a lot of teleconsultation and reduced the number of antenatal visits. I'm going to be talking about what we have actually done. It is not an academic talk, and I will be presenting to you data of real significance, what has been done in the past year, and what are the lessons we have learned from it. So ICMR guidelines are the ones which most of us follow. They keep changing, and the version of September 2020, which basically said that we need to screen pregnant women, those who are coming to hospital within 5 days of delivery, has been followed in most places and was followed by us even when in between version 5 said maybe it is not required. And we followed screening and triage preparations. So now this is a very important slide. After the pandemic was declared, when we started, we did not have the resources nor the facilities to test all patients. Some of you, unfortunately, may have also been in that situation. Things are changing, but sometimes in smaller places, we still have that problem. Where are we going to get the reports or testing done? We manage symptomatically and transfer high-risk patients to designated COVID facilities. But now, are we having beds? So what we did was first, patients were referred to fever OPD. But then we decided we as the department need to take that onus, and we trained our own juniors, and we decided we are going to follow the guidelines and start screening. So what I'm going to be showing you is 1 year, what we did was we tested everyone who walked into our labor room or needed admission from antenatal OPD with the RT-PCR test, which our own doctors started doing. And we asked for the swabs from microbiology. And we managed according to standard protocols. What was also important is healthcare workers were asked to follow standard guidelines, rational use of PPE kits, face shield, N95 masks. Now you will tell me, are you wearing PPE kits all the time? When I say rational use, it depends on the level of exposure, and that in fact can be a full talk in itself. But we have to remember that the use of the proper masking, hand hygiene, and distancing is the most important thing. This year showed increasing trend originally, but happily towards the end of the year there was a decrease. But now in 2021 it has again gone up. I will show you the numbers. And 2021 did not make corona go away, and everywhere a second wave has started. This is just showing you the numbers. The bottom is 554 cases when we are not a corona center. There are different levels: a COVID designated hospital, COVID care centers, and hybrid facility is what we are at. Now, if you look at this graph, it will tell you, rather than just throw numbers at you, the orange line talks about total patients coming to our hospital every month. We are a referral center on the western suburbs. You can see the number of referrals has not gone down. Little bit of fluctuation is there. But the blue line shows how many patients were COVID positive. We were very happy in November. It had gone down to 4 patients only when the number of cases was almost the same. But then happened Diwali. It was Adhik Maina. After Diwali, social festivals, again it went up. Again in January, went down to 6 and 3 in February. Again came Holi. And again the numbers have gone up and seem to be rising. So we have actually found, and what is also important is, patients have to be admitted and management done according to standard protocols. There is a lot of controversy and discussion about high cesarean section rates for obstetric indications. And at the end, towards the end, I will also share with you FOXI data. I am part of the FOXI COVID registry, and we are updating on that. And in our institute, we strictly followed obstetric indications for cesarean section, tried to give a separate isolation room. We are not a very big hospital. I came from KEM where Satish, me and his wife, Dr. Vaishali, were colleagues. It was a 1800 bedded hospital. Here, this was a 700 bedded hospital. How do we get place? But you have to carve out infrastructure in your available hospital. People with nursing homes tell me, doctor, how do I manage? You have to find place if you're going to deal with COVID and rationally use PPE, N95 and face shields. Another important thing which we found was the change in anesthesia practices. For example, early pregnancy failure, if possible, prefer medical abortion. If you require check curettage, we found anesthetists were switching from TIVA or short GA to saddle block because of risk of aerosol generation and wanting to avoid GA procedures. Having separate isolation wards or intermediate wards by screening the facilities is important. And we had actually created one of our wards as a ward for asymptomatic patients. And again, communication with colleagues. If you don't protect your team and there is inadvertent exposure when the report comes later, everyone is in a panic. And in fact, in the initial few months, we found there was a lot of chaos and panic. But once we had protocols in place, kept having weekly review meetings, refreshing what should be done with everyone, especially with the juniors, we found there was a more streamlined way of working. Test and treat. Now, this is a little busy slide, but it's a very important slide. There is a lot of confusion. A lot of you may be getting reports on WhatsApp now, and there are 2 CT scores which cause chaos. There is a CT or cycle threshold score of the RT-PCR report, in which if your CT score is more than 35 in the RT-PCR, it means it is a negative report. But there is another CT score of severity on CT scan, in which you have less than 8, 9 to 15 moderate, and more than 15 severe. So be clear when somebody is asking you, okay, this is the CT score, which CT score is being talked about. Another thing, sometimes radiologists give a CORAD score or level of suspicion for COVID-19. We have often had patients in pregnancy, often the CT scan of the chest or the HRCT is done after you have a positive report in a symptomatic patient. But in the gynac patients, you might get a patient walking in. For example, we had a patient for ovarian cancer surgery. A lot of people in private practice insist on a HRCT of the chest along with the RT-PCR report before putting them for any, even if it's a semi-emergency surgery, like a surgery for cancer or other surgeries which have suffered in the last year of corona pandemic. In fact, one of the studies we have done at our hospital has shown that simple things like pap smear screening and finding patients who come in late stages of cancer because of lack of access to facilities has been one of the unfortunate side effects of COVID, not directly, but indirectly on the healthcare system. Coming back to how to interpret investigations, D-dimer reports, CRP, interleukin 6 are also reports which are often done by the medical colleagues. Friends, as obstetricians and gynecologists, when the patient is admitted under us, finally we are responsible. Hence, we need to know how to at least basically interpret the reports and understand with a simple idea. Now, D-dimer, for example, can be given as microgram per ml, but some labs give it as nanogram per ml, in which case the report has to be multiplied by 1000. So if you're talking about nanogram per ml, then more than 1000 signifies moderate to severe COVID. And if it is less than 1000, it is mild case. Neutrophil to lymphocyte ratio is also important in a simple thing like the CBC. And reports like ferritin, LDH, and ESR will help you when you are thinking the patient is going into cytokine storm. You will think, why should I bother? It is not my job. I will refer to the medical colleague. But I'm telling you, friends, right now there is so much uncertainty and chaos. For our obstetric patients, we need to know and understand the basics and help our medical colleagues to decide what should be done in the best interest of our patient. Interleukin 6 is an important marker for the cytokine storm, and we have a specific drug for that, which I will be touching upon little later. Test, triage, and treat, and work in collaboration. Now, here what I've presented is actually what has been circulated by us in our hospital groups, which has been prepared as a protocol by our head of Department of Medicine, which we follow. You will see it's a very sensible way that when a patient walks into your fever OPD or a symptomatic patient comes to our OPD and we need to refer her, what should be done? Should you be admitting? Now, rather than read the busy slide, for obstetric patients, what is important is if she is away from delivery, she does not have comorbidities, you think it's a mild symptom or asymptomatic, you can consider home isolation and treatment with telemedicine if possible. But if she does not have isolation facilities, you may consider admission for pregnant patients, and definitely if she's having moderate or severe symptoms. Right now, with lack of availability of beds, we have to consider using the COVID care centers in between. But unfortunately, a lot of the centers have this fear that pregnant patients we cannot manage. So often we land up hospitalizing pregnant patients because of lack of facility of where to put them. This is just showing you this is a very important slide. Patients who came with pregnancy with symptoms, out of that, when we tested, you can see 54%, that is the green area, were symptomatic and they were positive. Whereas 46% had symptoms, but they were not COVID. But here again, remember, there is even the RT-PCR, 1/3 of them can be negative because of test-related issues or regarding timing of when the RT-PCR has done. So hence, we need to follow it up if the patient remains symptomatic and repeat the RT-PCR if you are not sure. The other side, the pie chart is showing the red area. 511 patients out of nearly 4,000 were asymptomatic COVID positive pregnant women diagnosed by us in 1 year, which is 11%, which is a huge number if you think about it. These women were walking around with no symptoms. They were admitted in our antenatal ward or in the labor ward next to a laboring patient. And we did not know they were COVID positive, which is the importance of following the universal precautions or protocols, because we find that this is a high incidence and this is the fact of the matter, which is why pregnant women should be treated and tested. This is important. So our inference was, and not only this, we also saw the meta-analysis of 13 studies of COVID. Initially, it was thought that mothers with COVID, there's nothing really to worry about. But a lot of the recent data have shown that especially if it is close to term, there is a higher rate of maternal and neonatal complications particularly preterm birth, fetal distress, growth restriction may be there in infected individuals. What I was talking about, the second epidemic wave, which has started in 2021, has also caused a different pattern of disease, which I will be coming to in a few minutes. But please remember that even whether it's first wave or second wave, we have an almost 11% asymptomatic positive pregnant women. Hence, all patients should be treated with proper precautions. Multidisciplinary or team approach is the way forward. Of course, we take basic observations, our good old partogram we used to always follow, but we used to not give that much importance to the respiratory rate, oxygen saturation, and puerperal fever was always defined as fever after 24 hours of delivery. But now, importance of fever in labor, prior to labor, and in the first 24 hours has changed because of corona. Hence, and that little machine, the pulse oximeter, which was previously not so important, is most important. And in fact, a lot of people now, most houses also have this along with the thermometer. People keep a pulse oximeter at the house and will tell you, okay, this is my oxygen saturation. In labor, FOXI GCPR guidelines have also said 95 or more is what you're aiming at for a pregnant patient in labor, whether she is COVID or non-COVID. Now, talking about cesarean section, I mentioned to you, even our FOXI initial studies have shown, and this is analysis of the first 8 months, we analyzed in detail section rate and compared it with patients who are proven to be non-COVID, what was the section rate. So this is important to tell you. Although overall our LSCS rate in the hospital was around 34%, in these 8 months where we are comparing COVID and non-COVID, the section rate is comparable. There was no statistically significant difference. We are doing sections only for obstetric indications. Unlike certain centers where because of fear or concern, and sometimes in private practice, some practitioners were telling me, the doctor, the number of PPE kits I will have to use, monitor the patient, it is better that I do the section and finish it off, it is much better. But the complications and the problems of cesarean section are also what we need to keep in mind. And even the FOXI guidelines, RCOG guidelines have emphasized, please stick to obstetric indications only for cesarean section. I talked to you that a fair number of patients who came to us had some symptoms in pregnancy. So these are pregnant women with symptoms who we had to section for obstetric indications, in which, as you can see, the predominant symptom was fever, cough, shortness of breath, sometimes bradycardia was also there. Out of these, I am happy to say that out of these, only 2 out of these 23 symptomatic patients had severe illness, and only 1 of them actually died. The rest of them recovered fairly well, and few required ICU admission temporarily after the section. Another issue is general anesthesia. There was no significant difference in the use of GA, but you can see the use of GA is very low, whether it is COVID positive or COVID negative, which is what we obstetricians have always been practicing. Unless your patient is breathless or has a problem for COVID, it is often not required. And in fact, for fear of aerosol generation, it is much better to go with regional anesthesia. Now, we were talking about indications for cesarean in COVID. What I would like you to see in this, the red areas I'm highlighting, don't bother too much with the numbers. But what is important is there was a significant increase in fetal distress, which is why even if she is COVID positive, we have to do a section. But conversely, what you must see, normally obstetricians, we do a lot of sections for oligohydramnios, PIH. But you will find that because the patient was COVID positive, we in our own hospital were more prone to try to deliver them vaginally because they do better and recover faster after vaginal delivery. So in fact, our section rate was much higher in hypertensive disorders and oligohydramnios in the COVID negative group. Pulmonary edema is something we obstetricians should also learn to deal with and identify. And we need to be a little more liberal with imaging. People are scared to do X-ray and HRCT in pregnant women. Please, friends, when it is required, it can be done. Some people have in fact even suggested do ultrasound to screen for COVID in pregnancy, but that is not practical. We don't have enough people trained. But if you have a patient with respiratory symptoms, of course, asymptomatic patients, I'm not recommending that you do HRCT as a screening methodology. But if you feel your patient is having some respiratory symptoms, Be more liberal with the testing. With an abdominal shield, it can be done. And beware of what we call as happy hypoxia. Patient seems to be okay, but suddenly over a couple of hours or sometimes even over minutes can crash if you are not vigilant. And again, judicious use of colloids and fluid balance is very important in these patients in labor. Initial studies said that obstetric patients don't have a problem, but now patients, and this is fair enough when the corona infection has occurred far from term. But when the patient is in labor, there is a definite increase in need for ventilatory or ICCU support. And here in our study, comparing the section rates in COVID and non-COVID, you can see it was hugely significant. Uh, uh, the difference in the two groups of those who required ventilator or ICU support was much, much higher in COVID. And this is supported by other international studies also. Severe ARDS with multi-organ dysfunction is one of the problems by which the patient needs to go to the ICU. Now, how do you treat? On the right-hand side of my slide, you all can see there is a COVID helpline, which our dear President, Dr. Alpesh Gandhi, had started in the beginning of the year 2020. And I was also one of the people on this COVID helpline, and we had tried to reach out to our FOXY members for this. Because everyone is confused. Honestly, I have answered a lot of personal calls and messages, and I'm still doing that because, of course, long distance is not possible in many cases, but people are confused because everything from antibiotics to Ayurveda has been used. Azithromycin, doxycycline were antibiotics which have been used left, right, and center. Antivirals, remdesivir, there has been a huge controversy and discussion, and I will be talking in little detail about this later. Anti-helminthics like ivermectin were first touted as the best thing after sliced bread, but now has been told it's a no-no. Our Maharashtra COVID task force has said, do not use ivermectin. Doxycycline, of course, we don't use in pregnant women. Azithromycin can be used as an initial drug, but there are many issues. Antibiotic cover is only given when you feel there is a risk of superadded viral bacterial infection on top of your COVID infection, and you're having to give high dose steroids. Hence, rational use of all these things is very important, which obviously I cannot cover in this next 20 minutes. But this, I've just put up this slide to tell you another drug, tocilizumab, is a IL-6 inhibitor. It's a monoclonal antibody. Friends, here I would like to share with you my own personal experience. Last year, I myself was hospitalized with COVID. My family had to run around, and that time also remdesivir and toci were not available. My family is full of doctors. They ran around because my husband admitted me in a private hospital. In fact, from BMC, I was told, Madam, aap BMC mein kyun nahi aaye? I was in no state to make any decisions. But they ran around, got the remdesivir and toci. But my physician felt, don't give remdesivir. It is not going to help at this point. And it was returned. And I was given 2 shots of toci, which people again say is a controversial drug. The Covacta trial said no difference in mortality. But for me, it worked like a magic bullet. And I did recover after that. So I feel it has to be something related to the physician's experience. Treatment is based on case to case, keeping the clinical scenario, the timing of the drug, the interpretation of the investigations. Hence, you need to be as an obstetrician also on top of things. You need to know what is the stage in which your patient has come. If she is asymptomatic positive, mild positive, we are not worried. But if she goes into moderate or severe disease, we need to have a basic knowledge and be in discussion with our medical colleagues so the right treatment is given at the right time. Steroids is one drug which has been touted as an important therapy in COVID, and I have to agree with that. But again, here a word of warning. Steroids should not be given too early in the phase of viral replication. It has to be given at the right time and only to patients who are showing hypoxia, fall in the oxygen saturation, and it has to be done in conjunction with your physician. Sometimes people have used, in fact, initially in 2020 at the beginning, certain well-meaning Rotary clubs and all were distributing homeopathy, 3 tablets of a particular medication saying this is going to prevent corona. Ayurveda was also being advised. Finally, it was Bhagwan Bharose. What is going to help a particular patient? Nobody really knew. So now I'm going to touch upon briefly what obstetricians need to know about the treatment protocols which work. Steroids, there is a recovery trial which has been discussed for remdesivir and steroids. But basically, betamethasone 4 milligram IV once a day or tablet 8 milligram twice a day, then tapered, has been used. Or prednisolone 40 milligram IV, because sometimes dexamethasone is not available. It's available only as a 0.5 milligram tablet. So it becomes difficult to give. But please remember, if there is no hypoxia, do not give steroids. Monitoring blood sugar levels is very important. I have seen many patients, and including myself, where the sugar level has shot up like crazy after giving the steroid. But we need to monitor, and if required, sometimes insulin has to be added even in a non diabetic patient. Watch for superadded infection, which is why sometimes antibiotic to cover is required. One very important drug is anticoagulants. Pregnancy and puerperium is a known prothrombotic state. This is where, even if you are not doing anything else, the low molecular weight, first of all is the aspirin. A lot of our PIH and other patients who are already on aspirin, if they are on that, please continue it. It is going to help them. Do not discontinue. Low molecular weight heparin and subcutaneous heparin are two options which can be given either OD or BD based on the severity of the disease. There is a Maharashtra Task Force 40-page booklet which I will be happy to share with you. If you, Satish, I can send it to you on personal message, which you can share with anybody who is interested, which is we are very clearly given guidelines in the first 10 pages of what is the report and accordingly what dose basic has to be given. This will help you to know. What I had talked about D-dimer and other tests. D-dimer is going to be elevated in pregnant women. And in fact, 3 to 4 times elevation of D-dimer is expected. So don't panic if you're getting a mildly elevated D-dimer. It does not mean your patient is going into cytokine storm. But if there is more than 4 times elevation, yes, it is an indication to start the anticoagulants and also to consider giving the monoclonal antibody or tocilizumab if required, if shown by other supplementary tests like ferritin or LDH being elevated, in which case steroids, heparin, and toci can be considered. Antivirals. Favipiravir has been one of the drugs which has also been given left, right, and center. There is not enough evidence of this drug or trials in pregnancy. It is not recommended in first trimester. Of course, it's out of the question. We do not recommend it as a drug of primary choice in pregnancy. And if required, another drug, oseltamivir, which was used for swine flu, was also tried a lot in the first phase of treatment of COVID in 2020. We have also used it in our hospital. We have used hydroxychloroquine also. Now, both these have gone out of the window. Newer studies have said, and in 2021, we are not using either hydroxychloroquine or oseltamivir. So what is important is in the evolution of knowledge of COVID and evidence which is coming about effectiveness of different drugs, we are finding less and less is available to us to treat. So up to now, from what I have discussed, judicious use of steroids, properly timed anticoagulant therapy are two things which are definitely helpful, and correctly timed antivirals. Now, remdesivir. Most of the guidelines have said if it is given when there is hypoxia before day 7 or maximum up to day 10, and there is moderate severity on the CT scan score, you can give 200 milligram initially and then 100 milligram once a day for 5 days. Initially, people were only giving it in ICU settings. Can you give it in the ward? Now, in fact, recently in the University of WhatsApp, people were suggesting if there are no beds, start giving the remdesivir at home. But is this possible? Is it feasible? For pregnant women, definitely it is not advisable. Efficacy, it has not shown to improve mortality when used alone. But when used along with steroids, it has reduced the intensive care requirement and has improved certain endpoints. So the third thing which can be used in your pregnant woman if she's deteriorating at the correct time is remdesivir. Another big controversy is convalescent plasma therapy. Mumbai Dhadkan is one of the organizations which is working on it. Association of Medical Consultants has also tied up with it. One of my colleagues had set up a helpline for this. But friends, unfortunately, there is no evidence saying that plasma really works. But if your physician is recommending it, again, as I said, there is no magic bullet. But if you have gone to a person you trust and you feel that this is the right advice, definitely do try to follow that. But keep in mind that very few therapies have been proven to improve the outcome. So don't feel that my patient is suffering because I am not able to get plasma. It may not be true. Dr. Zarir Udwadia is one of the very famous chest physicians from Hinduja, Mumbai. And I believe that we have to update our knowledge. So I was actually listening to him, and these are 2 or 3 very important points from his talk, which I thought I should share with you all as obstetricians and gynecologists to know. And he very succinctly said that there is no statistically significant effect on mortality with remdesivir in any patients. And he has said that yes, there is certain improvement or speedier recovery in certain subsets, more effective in those who receive it within the first 10 days rather than those who receive it after 10 days, which is a basic guideline which we have anyway been following in our hospital. Another important slide, which I feel, which Dr. Zarir talked about, which I felt I should share with you verbatim, was, which I also believe, is there are very few proven treatments for COVID. But for our pregnant women, these three, steroids, judiciously timed remdesivir when required for moderate to severe disease, and low molecular weight heparin are the ones which have some evidence of benefit. Friends, majority of patients may get well on their own without any treatment because the healthy immune system is the best defense. But pregnancy is always thought to be a relatively immunocompromised state because the fetus is beautifully described as a paternally derived allograft in the mother's womb. So pregnancy is thought to be a state of relative immunodeficiency. But most of our asymptomatic or mildly symptomatic pregnant women do well if they don't have comorbidities. I'm happy to say that. Sometimes we feel under pressure that we need to prescribe, and that's what Dr. Udwadia said, that we feel pressurized to prescribe drugs because they are expected by the patient. But some drugs may do more harm than good. So, what have we learned in this time? Steroids given too early can in fact increase viremia. So usually, as I already mentioned, give it when there is prolonged fever, high CRP or hypoxia, and usually after the 5th day of symptoms is when people usually recommend starting the steroid. And if you do the HRCT very early in the disease, you'll get a false sense of security because initially in the disease, you will have normal or low scores. But if you have a patient who is symptomatic or respiratory symptoms develop, the HRCT should be done in the 6th or 10th day. And that is when the scores can indicate the severity of the disease better. 2021 strains, especially what we are labeling as the mutant strains, some unfortunately seem to be resistant to FabiFlu and remdesivir also. And FabiFlu is not a drug which does not have side effects. It can cause mild elevation of liver enzymes. It can cause nausea, vomiting, and a rise in the liver enzymes. Hence, we have to monitor that if you use that in your patients. So ultimately, what are we left with? Supportive treatment in mild, oxygen, steroids, low molecular weight heparin in moderate to severe disease. Friends, this is some data from Yale in the USA, which was published when they analyzed almost 4 lakh deliveries and found across the United States 6,380 COVID positive women and compared them with the COVID negative women. They found that women who had a COVID positivity were tended to be younger, and in that country they were of certain ethnic groups and were obese, but higher rate of cesarean delivery, preterm labor, which we also found, and importantly, higher risk of thromboembolism and admission to ICU, which I have also mentioned. This is just a slide showing the relative risk or adjusted risk ratio of all the various conditions. Stillbirth was also mentioned very beautifully from the data of NHS by Dr. Patrick O'Brien in the RCOG webinar, that there is some increase in stillbirths due to various reasons, not necessarily attributable to COVID itself. We found in our study, where we compared the sections, only one maternal mortality in the COVID positive and one in the COVID negative, but the difference was not significant. But having said that, in the full last 1 year of COVID, in the 10 maternal deaths we have had, 4 were related to COVID. But now statistical inference is a little difficult for that. Before I go to vaccination, a few words on postpartum care. There was a lot of confusion with ACOG had given some different guidelines at the beginning, keep the patient away, baby should be isolated, all that. But basically, Municipal Corporation of Greater Mumbai, consensus with the neonatologists, Maharashtra Task Force has basically said, with consent, using proper precautions, hand hygiene, you can keep the mother with baby, especially if you don't have other facilities. And if you are separating mother and baby, still express breast milk or allowing her to breastfeed with precautions and then keep the baby away with one attendant who is diagnosed COVID negative, who also should take precautions, is important. Neonatal outcome. We find that only 6.34% of our babies tested COVID positive in this entire huge number of 500 plus COVID positive mothers, because we do the RT-PCR 48 to 72 hours post-delivery is done by our neonatologist. And the difference in neonatal deaths was not significant. This, our president, Sir Dr. Alpesh Gandhi, is going to publish our findings from the National Registry. But in the preliminary analysis, where we are also submitting our cases, from the lockdown, that is from April to August 2020, across our country, 2,700 cases have been reported from across 60 institutes, and almost 7.2% required critical care. In the FOXI registry, almost 60% were delivered by section in the initial phases, which I told you in our study is 40%, because we are more judicious and we are following obstetric indications. Stillbirth and IUFD were seeming to be a little more. Before we talk about vaccination, two other specific terms which have come up in this year are what they call as long COVID. Long COVID is when, after the patient seems to have recovered from COVID, they are still not fully well. They are coming to you with complaints. And a lot of our postpartum women do complain of fatigue, backache, breathlessness, tiredness. But there is a specific syndrome called post-acute sequelae of SARS-CoV-2, which is described as a symptom which can last for as long as 9 months, which is why follow-up care, proper physiotherapy, nutritional advice, breathing exercises are all very important. In fact, prone position sleeping or a change in position was one of the therapies which was initially mentioned right at the beginning in 2020 in management of COVID patients. And it was suggested that giving a prone position for sleeping, which technically was seeming a little difficult to do, I know because I have been there and tried to do that myself. It was very difficult to sleep in the prone position, but that does improve the oxygenation. But even afterwards, it has been suggested there are certain positions which patients should be recommended to relieve breathlessness. Lung fibrosis is a problem with COVID, especially those who have had high flow oxygen for a long period of time. And now with oxygen shortages, we are moving towards trying to conserve oxygen use, reduce the oxygen use, not just for saving the oxygen now, but also it has been found that the long-term sequelae of COVID or the effect on the lung is more in patients who have had prolonged exposure to high flow oxygen. So friends, we come to the last part of my talk, that is prevention is better than cure. We all know we are talking about first wave, second wave, herd immunity, and other things. Can COVID really be prevented? And in fact, this was certain data I presented at our annual MOGS conference, which just happened last month in collaboration with community medicine. Although Satish described me as an academician, I would like to say that here I'm trying to tell you from what we have actually done in practice so that we know what is the reality of the situation. Since our government gave a notification way back that we need to see that vaccination is implemented because there have been many COVID deaths, our institute, that is Cooper Hospital, was one of the 10 nodal centers identified by the Prime Minister's office to launch the nationwide vaccination drive in January 2021 because hand hygiene, testing, social distancing have not worked completely to control cases and deaths. These are all the vaccines available globally, and numbers and other things are being added to it. The mRNA vaccines are not the ones marketed or available in our country, but what do we have in our country are these two. Covishield, which is an adenovirus modified vaccine which cannot cause the illness, with the spike protein which is found. Initial studies said 62%, but it has been now suggested the efficacy of Covishield can be up to 90%. Covaxin, developed by our own, made in Bharat, Atmanirbhar Raho, is with ICMR and NIV, a killed vaccine, samples which are available. And in fact, there has been a lot of discussion that is Covaxin better than Covishield. But having said that, I would say that whatever vaccine is available, people are taking it. Vaccine efficacy, these are certain studies which have suggested that, as I was talking about it, the efficacy from different studies, what we call as Oxford or AstraZeneca vaccine to the spike protein or the viral vector vaccines, up to 82%. And doses initially was said 4 weeks apart, but now it has been suggested up to 12 weeks apart may be better. The Covaxin from Bharat Biotech also 81% efficacy. They have still suggested 4 weeks gap, and they have suggested it might be better for the other viral strains, but we don't know. Johnson & Johnson had marketed the viral vector vaccine, which the best advantage was it was supposed to be a single dose, which was a huge advantage with a 72% efficacy. There has been a lot of controversy. In our own hospital, we had, in the 2 months we studied, we started on 16th March 2021, and I am presenting to you the data we analyzed for the first 2 months when we only had Covishield. After that, we got a few doses of Covaxin. I analyzed this with respect specifically to our department because we had a lot of anxiety about side effects. And when we started giving vaccine across in our hospital, this is now over 2 months, was almost 27,000 doses were given, of which around 5,500 were fully vaccinated. Covishield, you can see that the healthcare workers, frontline workers, 45 years and above, senior citizens, all were vaccinated in the first few phases. And it was only after the first 2 months that the others have been started. But in this first phase, you can see these are our department members, gynec department. Unfortunately, in the first week, 0 people from our department got vaccinated. One thing was that the healthcare people felt, this was just a chart showing all our department members. The administration also felt that gynec people are not frontline or important. It is the fever OPD or the other people. And we were not given the opportunity to get vaccinated. After we approached them that we are also requiring, it was only 8 in the second week, and then gradually it went up before we got most of our team vaccinated, which was important. And why was this vaccine hesitancy? People were worried. Then people said, Madam, mera duty hai. My senior is not letting me go because then I won't be able to labor ward call. Let us wait and see how the others respond to it. I have already had COVID. Why should I take the vaccine? Some people have said there may be some fertility concerns. So these were all the concerns. This is showing you from our hospital, the data reported only 51 adverse events following immunization. Initially, hesitancy was because one of the doctors from community medicine himself developed high fever for 2 days, but fortunately he recovered completely. There was only one case of local cellulitis and one case of chorioamnionitis in a nurse, but we were not able to identify whether it was truly vaccine related or pre-existing issue because she was also diabetic. So bottom line is, there did not seem to be too many adverse effects following vaccination. Primarily, we have to do no harm and we have to assess the balance between risk and benefit. So, of course, proper use of social media. When we started taking the vaccination, I was one of the first people in the department who, along with one of my junior residents, went and got the vaccine and put it on the department group. And with that, then another group of our people followed. So, we need to set an example, encourage the juniors to take what healthcare is available, motivate them, have discussions to allay their fears, proper audit, and review meetings. Now, this is an important slide on the left, the definition from ICMR of what we call as reinfection. ICMR has analyzed its database of 8 crore individuals to know, and what they have said is reinfection is when you have a positive test after an interval of 100 days plus with one test which was negative in between. Then only you can label it as reinfection. In fact, double mutants, and this is a cause of concern, which is what is going across the media. Another important thing is vaccination and clotting. This slide, the blue area, shows you very beautifully the risk of clotting with various diseases. With corona infection itself, there's a 16.5% risk of clotting. But with the vaccine, it is less than 0.004%. Yes, rare syndrome of low platelets and cerebral venous thrombosis has been reported in few cases, particularly in younger women. Hence, we need to be vigilant about this. But various guidelines from European societies and others have said the risks from various other things are much more. Do not worry about this. And in fact, other concerned people had, I am on a blood thinner, can I take the vaccine? So HEMAT societies have also come out with a guideline that most of the people on the basic blood thinners can be vaccinated, as seen in this red slide on the other side. This is of 21st April, just yesterday, media briefing put across from our National Information Bureau based on ICMR data. People were worried that I have taken vaccine and has that given me infection? This was showing across the country, Covaxin 1.1 crore people have been vaccinated. Covishield 11.6 crore. People who have turned positive after the dose is extremely low. And sometimes it could be just an activation of an infection which was already there or underlying. Hence, friends, do not get scared or become go into vaccine hesitancy. And another important thing is COVID vaccination and death. There was one anecdotal report of somebody who went to a private hospital, took the vaccine, after half an hour observation, went and sat in the rickshaw and had a cardiac event. Was it really related to the vaccine? So there are a lot of issues in this, but it has been found, this is again from CDC about, and this was accessed on 14th of April, which is very recently, that the vaccine is almost 100% protective against death. And death due to the vaccine is almost negligible. And we cannot say that the person, and it's very difficult to identify that may be a pre-existing cause which has led to that person's death. International media is pointing fingers at us, friends, saying that how our health system has collapsed. There are many negative reports coming up across our country. We have to introspect and see what we can do. There are times when I also feel I am helpless. I receive calls, doctor, can you get me a bed in Cooper Hospital? Can you get me a bed in Seven Hills? Where can I get the medicine? I have said no many times. But what do we want to be in this COVID-19 times? In this last 1 year, friends, we are moving from the fear zone where initially I have to say all of us were very afraid, we did not know. And fear of the unknown is more, जो नहीं मालूम उससे भी डरते हैं. Then we learn from what has happened. We have audits. We learn how we can manage a situation better. And then we come to a comfort level where we know what should be done, we grow in our thoughts, we are able to help others and move in a positive direction. So, friends, don't lose hope. Atmanirbhar raho, try to do whatever you can in your own circumstances. Remember that corona is affecting us in many, many ways. Need of ICU admission in our pregnant women is more. Don't go for section for corona, but go for obstetric indications. Steroids, remdesivir, low molecular weight heparin given appropriately are the only proven drugs so far, but leave it to a multidisciplinary approach. But you as obstetrician need to know about it. But remember, no drugs have changed mortality. It is the inherent immunity, the comorbidities which are really the impacting factors. Yes, the second wave is more dangerous, but vaccination and herd immunity is the way forward, my friends. Follow protocols, triage your patients, maintain the registry, prepare your facility and your team to work better, and together everyone achieves more. Identify areas for doffing, proper disposal of what you think is infected gear, because otherwise it defeats the whole purpose. So protect yourself and move forward. And that is the only way we are going to face this pandemic in a positive manner. And I thank my COVID warriors. These are some of my team who have been working around the clock. I thank our Dean, Dr. Gujjar, for permission to share hospital data, and MOGS VCare, which actually, and also Association of Medical Consultants and other organizations which came and helped us with PPE kits, face masks, and other gear when we were running short in the initial phases of the pandemic. So, friends, let us work together to make a difference. And I'm sure each of you will be able to move forward despite these difficult times. And these are some of the references from which some of my studies have been quoted. And I thank you all for a patient hearing, for being here with me. And I'll be happy to answer any questions, Satish, in the next few minutes. Thank you very much.
Thank you, Reena. It was an excellent presentation. And I'm sure there will be, if there are any questions, we will take them. But before that, we have Dr. Adi Dastur, who is going to join for some concluding remarks before the question and answers. He is the former Dean of Nauroji Wadia Hospital. Sir.
So I believe sir is not here right now with us.
Okay, so we will start with the questions.
Yes, sure.
So Satish, can I suggest that one of you will collate the questions and one of you can ask me, because sometimes we have repetition. Yeah.
Yes. Dr. Rajeshwari.
Yeah, sir. Ma'am, thank you. Very wonderful lecture, and all practical aspects were covered. Ma'am, there are few questions. Some have them, they have posted on the WhatsApp also. They want to know, like, COVID positive patients, like how many of them, though they were stable at admission, and how many of them have suddenly dipped with oxygen saturation and gone into breathlessness post-delivery or C-section? Means, is it quite common? They want to know.
No, I am happy to say that when you have detected somebody who is asymptomatic positive, very few of them have deteriorated, almost zero. But in the symptomatic patients, you have to be very vigilant. Even if there's a single symptom, for example, just a fever or just a little bit of cough, it's something you have to be vigilant. I would say about 25% of these symptomatic patients can deteriorate. But even then, if you are vigilant and maintain the oxygen saturation appropriately, most of them do very well. I have had a fair number of patients. In fact, just this weekend, we did a elective cesarean section for a 39-weeker with hyperthyroidism, initially tested COVID negative. Section done, she went into thyroid storm, went to the ICU. Despite everything else settling, again, third day she went into hypoxia. COVID test came positive. So it is possible that sometimes patients are in that window period and have not been diagnosed. So hence, when there is hypoxia or symptoms, we have to think COVID in these times. And symptomatic patients, we have to be very careful. But asymptomatic patients, 95% of them will do very well. So don't worry.
There's one more question. These symptomatic patients who have recovered from ICU admission and all antenatally, is there any effect on the fetus? How long they can continue? Whether the fetal demise is more or oligohydramnias in such cases?
So, the effect on fetus, one thing is there's a higher incidence of preterm labor. A smaller but not a significant, definitely preterm labor is increased in many studies, not only our study, but also reported by RCOG and other places across the world. Stillbirths have increased marginally, but that is not necessarily only because of COVID. It is also because people don't access the healthcare system in time, or there is a delay in intervention because she is corona positive. By the time you mobilize the OT, you get the PPE and other things. So that is one of the unfortunate, I would say, the collateral damage which happens in COVID. But there is no direct correlation of corona causing increased stillbirths. As far as the baby goes, I have already mentioned that with proper hand hygiene and precaution, unless the mother is sick and in ICU and unable to feed, in which case you have to think of alternative methods of feeding. And if she is well enough to express the breast milk, it can be given as EBM or other human milk sources can be given. But माँ का दूध अमृत जैसा है, we continue the breastfeeding and most of them do very well. Long-term sequelae of corona, we have not had any neonatal death in our study due to COVID so far, which I am glad to report, but we are still following up the cases in the OPD.
Answered. Even there was a one question on breastfeeding that also has been answered now. There is one question: is it advisable to keep iron sheets between mother's face and rest of the abdominal parts and perineum?
Sorry, I missed the.
Is it advisable to keep iron sheets between mother's face and rest of the abdomen part and the perineum?
Yeah. So, in fact, partition between the face and the perineum, will that really help? Most important is we should keep a mask on the woman. Even if she's in labor, at least a 3-ply surgical mask should be worn by the patient, more than a sheet, because the aerosol generation as the woman is breathing in labor is a problem, unless she's already on a bag. And in fact, that is why it is important to have the respiratory protection. Another thing was there was a little bit of concern if the amniotic fluid splash and other things are also sources, which is why the face shield is also important for us as obstetricians, not just at normal labor, but also at cesarean. In both cases, the foot protection and the splash protection is important. So just keeping that bed sheet in between is not useful. It's more important to make sure your patient is wearing a mask when the patient is in labor or a section is going on, even under regional. Unless the anesthetist has kept that bag or the mask on her face, she should be wearing a mask. Another common question, I think Dr. Rajeshwari is muted, but was you have these very fancy respirators, which have that suction and attached to a negative suction thing, which is used. Unfortunately, in our public hospital, we don't have access to that, and that is not available or possible. But some private hospitals have access to those kind of devices. Especially, there was an issue of whether laparoscopy can be done. Now, for laparoscopy, it is thought that is an important area where you are generating aerosols and you require general anesthesia. So hence, that is, of course, another area altogether. But in certain, I have a lot of my colleagues who are expert laparoscopists. And if you have set up the negative pressure and the flow in the OT, and you have the respirator kind of equipment, with proper care, you can do laparoscopy also. Having said that, in our hospital, because of infrastructure and availability problems, we are trying to avoid and go for open surgeries because our anesthetist team has requested us to do that.
What is the opinion about the Lancet study in support of airborne transmission of SARS-CoV-2, which actually mentioned in last few slides?
Yes, so that about airborne study, airborne transmission of SARS-CoV-2, that is one thing which has been, it's difficult to prove, but that is the reason or the logic behind why we are talking about a consistent, proper use of masks. And in fact, it has been said, even if you don't have the N95 respirator, having a 3-ply mask with a cloth mask or double masking. Dr. Anthony Fauci, who is one of the leading people who has been talking about prevention of COVID and is all over the media, himself was picturized wearing a double mask of 3-ply and a cloth mask. If you don't have N95, that is also good enough, because for airborne transmission, that is important. And what is also important is the person opposite you also should be masked, which is why I mentioned that in fact, when I take rounds, if the patient is not wearing the mask above the nose, I say, I will not see you. And I keep repeating myself to the security guard and this, please take rounds and encourage people to have proper masking with the mask properly covering the nose, preferably a mask with a clip. And in fact, it has been suggested in your hospital, if your patients have come without mask, you should also keep masks and hand it over to them and their relatives, because this way you are protecting yourself and your team. So for airborne transmission, it is not just you, but also the opposite person who should be uh, wearing the proper mask.
There are a few questions mainly on the vaccinations. Can it be given during pregnancy, and which is better, whether Covaxin or Covishield?
So here, in fact, I'm happy to say right now we are working on a FOXY GCPR guideline for vaccination in pregnancy, which is going to be put up on the website. And the bottom line of that is pregnancy and lactation is not a contraindication to vaccination. The RCOG and the ACOG have already come up with statements saying that it can be offered to pregnant women, specifically women who are working in the healthcare sector or who are exposed or at risk. Definitely should be proactively offered the vaccine. As always, we prefer killed vaccine to a live vaccine, which means if you have access to Covaxin, it is better. But having said that, if it is not available, even Covishield can be given. And ACOG has in fact published preliminary data of 90,000 pregnant women who have already been vaccinated in America, but they have used the mRNA vaccine, which is not the live attenuated version. But with mRNA vaccine, more than 90,000 women in pregnancy have been vaccinated. And hence, and FIGO has also come out in March 2021 with a statement saying that pregnant women and lactating women who are at risk or exposed should be offered vaccination and should be given with due risk. Now, what is important is our other vaccines in pregnancy, like Tdap or whatever else you want to give, the spacing between that vaccine and this vaccine has to be kept in mind. You cannot give the vaccine within 14 days of taking another vaccine. So these few practical points need to be considered. And we are going to upload this GCPR on the FOXY website very soon with President Sir. We are working on it. And once it is fully approved, it is going to come on the website. But basically, FOXY statement is also suggesting that vaccination is the way forward and we should not deny it to pregnant and breastfeeding women.
How long we can give low molecular heparin in symptomatic patients?
So in fact, for moderate to severe symptomatic women, low molecular weight heparin is a very good choice, because when the patient goes into labor, you just stop it for 12 hours. In fact, I was talking about our symptomatic section patients. We, in fact, restart the low molecular weight heparin 12 hours after the section, because we are relatively confident about our hemostasis. And these are the patients who are likely to go into thrombosis. Patients who are obese, patients who are diabetic, hypertensive, even if they were non-COVID, we are quite proactive about using LMWH prophylaxis. But those who are COVID positive, if the first 12 hours have passed without any bleeding, we definitely give LMWH prophylactically for the first 5 to 7 days post-op until they are ambulatory. It should be given.
Quite many questions on vaccination now. we want to know women who had this thrombus episodes following vaccination, whether mostly they were on OC pills. Is it whether it was common in those patients?
You know, to be honest, I myself have to study little more details of this, but the initial few reports were that it is very rare. It is like 7 cases in 1 million, which is extremely low. And they did find that women may be having certain pre-existing prothrombotic states. They are analyzing those cases, and paradoxically, they do show low platelets first and then land up with cerebral venous thrombosis. And they have said that you have to keep a watch for signs like severe headache, transient loss of vision occurring 5 to 7 days after the vaccination. So we have to give that warning, and which is why in our country, of course, we have not yet started vaccinating younger people. So we have not reported these cases here. This has come from other countries. But still, despite this, the European Union has come out with an interim guidance that these fears of the thrombotic events should not stop your vaccination. The Covishield and others are still safe despite these few isolated episodes, and we need to be more vigilant and give proper advice. And as you rightly pointed out, women with risk factors can be triaged by taking a detailed history. If you feel there is something, definitely keep a more watch on them. But it does not mean they cannot be given vaccination. Those who have allergic reactions or are on high doses of blood thinners or high doses of steroids or renal failure or on active chemotherapy at present are those who may not be given vaccine. But I have recently had a discussion with a chemotherapist about a patient who came forward saying that a well-educated patient who had was to start on chemotherapy 2 weeks later. She had just been operated for uterine cancer. So the chemotherapists themselves have advised, yes, give her the vaccine, and then next week send her for chemotherapy. We will start. So that is the way forward.
What is your experience about people who have infection post-vaccination?
So that was the slide I had shown you, if you remember, in the last couple of slides. That is our data from across the country. To attribute the infection directly to the vaccination is very difficult. It is usually something which was pre-existing, which may have got flared up or aggravated by the immune response when you received the vaccine dose. Because when you say ki 2 days after vaccination, I became COVID positive, it is probably an exposure which was earlier, which may have got aggravated or inflamed by the immune response to the vaccine. But this has been actually said that it is extremely low, and it is not any reason for people not to get vaccinated because of fear of so-called becoming positive due to vaccine. It is not true.
Questions on airborne and once COVID is detected in mid-pregnancy, should the aspirin be continued throughout the pregnancy, as the pregnancy is again the thrombotic prone for that?
If the COVID was detected, say at 24 weeks, and you have started her on aspirin or other things, definitely you would continue it up to 34 weeks, watch for PIH or other things. But if there is no other obstetric indication, she has turned COVID negative, at 34 weeks, you can consider stopping it.
And vaccination is best during which phase, like first, second, and third trimester, which is the best time to be given and which is the best time to be avoided? Because there are two questions they are come up with that.
Yeah. So honestly, there is not enough data of vaccination in the first trimester, and the initial, in fact, I would say right at the beginning when vaccine started, our government had given guidelines, WHO had given guidelines saying, do not vaccinate pregnant women. Even the RCOG had done that, but they have done a complete turnaround, and WHO has also said pregnant women should not be denied vaccination because they are people who will have more sickness due to COVID. Very clearly, it has been said that women who have taken the vaccine and then accidentally found that they were pregnant just around that time, it is not an indication for termination, which means that if it is given by mistake in the very early trimester, not to worry, but actively in the first trimester, we avoid giving vaccine. Second and third trimester, there is no problem. Whichever vaccine is available, if she's eligible, she should take it. There is no problem.
Very nice.
More than the questions, there are quite many appreciations, claps and hearts for the presentation, ma'am.
Thank you so much. I feel it's such an important discussion, and thank you, Satish, for inviting me, because it is something which I feel is the need of the hour, and I think this topic is very important, and I'm glad you have covered it for your society.
Reena, you did a fantastic job as usual. And if there are no questions now, can I request our secretary, Dr. Hema Patil, to propose vote of thanks?
Hello, am I audible?
Yes.
Okay. Thank you, Reena ma'am. That was a wonderful lecture and so many practical inputs. And it's indeed my pleasure to propose a vote of thanks. And with your experiences and insights into COVID and pregnancy, you have made us a lot more clearer in our concepts. And next, I would like to thank the office bearers of ICOG for awarding the ICOG credit points, Dr. Mandakini Meg, Chairperson, ICOG, and Dr. Parag Biniwale. I extend my thanks to our President, Dr. Satish Dhamankar, and Treasurer, Dr. Rajeshwari Patil, for their immense efforts in making this webinar possible. Many thanks to all the executive members of blogs for their valuable inputs, and my sincere thanks to Walter and Bushnell and their team for their technical support. Last but not the least, thank you to all the delegates who have logged in and actively participated with their doubts and so many questions. And I hope it was helpful to all of us in one way or the other. Thank you so much. Thank you, one and all.
Thank you, everyone. Dr. Adi Dastur has joined?
No, sir, not yet, sir.
Not yet? Okay, we will miss him.
Yes.
So thank you very much, Walter Bushnell, once again, and thank you all the delegates for participating, and Dr. Reena for making this webinar an excellent one. All the doubts, all the queries have been answered, and we are all ready to face the world now. Thank you.
Thank you very much. Thank you. Pleasure to be here with you.
Thank you.
Thank
Sir,
you very
with
much.
permission,
Thank
should we
you, ma'am. Thank you.
conclude this? So we are concluding this webinar. Thanks.